Hello, everyone. I would like first to thank very much Ruby Panwaka. Professor Ruby has been very supportive on this task. Back in the day, she was chairing the World Allergy Organization. And again, she gives us the opportunity to talk about the international classification of diseases and the tremendous improvements that have been made for the past couple of years. The international classification of the diseases is actually a tool that is made available by the World Health Organization for years in order to have a global assessment of mortality and morbidity worldwide. Its importance has increased over the past years. It's been used by more than 100 countries, translated into 43 different languages, and is actually used both in clinical care and research, as well as to manage healthcare, including allocate resources. Nowadays, about 70% of the world's health expenditures are allocated according to the International Classification of Diseases, and it is said that almost 100% will be allocated according to ICD in the coming years. Currently, we're using the ICD-10 and adaptations for several countries. Well, let us go back in time and talk a little bit about the founder of the International Classification of Disease, a statistician of the city of Paris called Jacques Bertillon, who actually created the classification of causes of deaths that he presented in the United States of America at the end of the 19th century and became immediately famous for his classification. So famous that the first international classification actually started in 1900. You can see on this slide that many other versions have been developed over the years. And down to the slide, you can see that we are now, since 1994, ruled by the 10th version of the International Classification of Diseases. Well, this 10th version has actually been validated by the World Health Assembly in 1990. It's made of 22 chapters that are basically grouped by organs. And there are more than 15,000 different codes that allows us to code diseases. And if you go into details into the title, you can see, for example, the number 7, which is disease of the eye and anexa. And you can go down to the list and see that the famous, for us allergists, chapter number 19, which is called Injury, Poisoning, and Certain Other Consequences of External Disease, is quite vague. And that is where our anaphylaxis disease is. Well, just to say that the 10th version is actually not appropriate for allergic and hypersensitivity diseases. Why? Because our 92 entities are actually scattered all over 6 different chapters, as listed on the right-hand side here. And for example, asthma and rhinitis are in the same chapter of respiratory airway diseases. Conjunctivitis is in another chapter. Look at skin disease. Dermatitis and urticaria are in the proper chapter, but angioedema is scattered in 2 different chapters. When you go down to food allergy, drug hypersensitivity, it's even worse. And the worst of all, down to this table, is anaphylaxis, again listed in the 19th chapter. So allergic and hypersensitivity conditions do not have a clear identity in ICD-10. Let's have a closer look on this chapter 19, which is right before the chapter 20, which is external cause of morbidity and mortality. You see, those things are coming vague now. And this chapter is called injury. And you can see that anaphylaxis is there. Adverse effects not elsewhere classified. It's not very promising. You can see, for example, for food-induced anaphylaxis, that this is the only place to find it. It's even worse. as most of the anaphylactic reactions are not unspecified. You can see that the only way to code anaphylactic shock is to use this code of unspecified anaphylactic shock. So that would select the most severe grade 3 aspect of anaphylaxis. So you cannot code a grade 2, for example. And in this very sub-chapter, you can see that you can find angioedema, or you can find allergy unspecified, that is very often ticked in order to ease doctors' coding work. And this is really misclassification and an awareness of our concepts. So together with Luciana, who approached me some years ago, she had the chance to have the access of the deaf certificates in her country, Brazil. And she could have a close look to more than 3 million deaf certificates, and she found almost 500 anaphylaxis deaths, which were not coded properly by the system. In the Brazilian system, using the ICD-10, you could see that nobody dies from anaphylaxis, although almost 500 could have died for anaphylaxis. And how she did that, she used extra information derived from the contributing cause of death in order to get the final diagnosis. So we were aware that the 11th version was on its way. It was internal in WHO since April 2007. We jumped into the revision process in 2011, when the 11th version was actually open for criticisms and open for inputs from external bodies, including a lot of bodies, but including doctors. That's when we started with Luciana to work on that topic and try to push the walls and get a better classification of our dear allergy and hypersensitivity conditions. Thank you.
Hello, everybody. It's a great pleasure to be with you in this APAAACi webinar. I would like to first thank you very much for this support and kind invitation from Ruby Pawanker, who have been supporting us over the last 8 years, in which the initiative Allergy in ICD11 has been taken. So my task here is talking about this topic, and for this in the next slide I will present our agenda, in which we will now have next slide please. Okay, so we will take this agenda in which, in fact, in the first topic, we will have just a big picture of what's going on related to allergic and hypersensitive conditions in the ICD, and then we will move on for the actions we have been moving in the Allergy in ICD11 initiative. So I will start now in the next slide with the big picture. So we do know that allergies have been known as very complex conditions, in which many conditions are grouped, having a great impact in the quality of life of patients, and as well as being life-threatening in some conditions such as anaphylaxis or severe asthma. And we do know that that data have been showing that allergic and hypersensitive conditions have been increasing in terms of epidemiology. And in fact, it's estimated that in Europe, in next 5 years, 50% of the population may be allergic. Of course, it may be extrapolated in other world regions, such in Asia as well. So now I would like to invite you to have a look the next slide, what's going on related to the classification of allergic and hypersensitive conditions in the ICD-10. So as mentioned by Pascal in the previous presentation, most of the conditions of related to allergies have been classified related to chapters which address specific topographies. So, for example, we have upper and lower airways in the chapter 10 and so on. But however, the classification was not really precise and not really good in terms of terminology and classification and definitions. And the question and worse of above all situations is related to the complex conditions in which we have more than one system manifested in the reactions, such as anaphylaxis, drug hypersensitivity, food hypersensitivity, and so on. So it reflects in clinical practice. For example, in the clinical trials we have been performing in terms of allergy. If you can see in the next slide, for example, we can see that only, you may know this platform, clinical trials, because all the clinical trials nowadays should be recorded in this platform. And when we search by the term anaphylaxis, all the clinical trials addressed to anaphylaxis correspond to 0.7% only from all clinical trials related to allergies. For example, next in Europe, we have some clinical trials, mostly in France and in UK. And in practice, in Asia, we have here mostly in China and Australia. Next, please. And it reflects in clinical practice because we have been searching the global availability of adrenaline auto-injectors here that is only available in 35% of world countries. As you can see in this slide here, all these countries highlighted in gray are those in which we do not have adrenaline auto-injectable for patients with anaphylaxis. It means that the patients are dying outside the health system. So the conclusion of this is that the ICD in general is highly important in terms of giving the visibility of some conditions such as allergic and hypersensitive conditions. So when they are not well classified and they are not present in this international system, it means in fact that we do not exist. So we are not visible in the global epidemiology. We can see in the next slide that of course, we were not happy with this condition, and so why, together with Pascal Demoli, we started the Allergy in ICD11 initiative that we will. I will explain in the next slide the details of this. So we started in this initiative in 2012. Triggered by the research presented by Pascal, based on the anaphylaxis deaths in the Brazilian system of notification, and in which we did not have any notification of anaphylaxis deaths because anaphylaxis has never been considered underlying cause of death. And it's of course not related to anaphylaxis, it's related to all allergic conditions. So this work started in 2012, triggered an initiative that was really academic and evidence-based, in which we try to trigger the communication with the WHO and provide them evidence-based data, published data, in fact, in order to prove the need of changes in favor of the better representation of allergic and hypersensitive conditions. Of course, this process started in 2012. we had great support from the allergy academies. So we had the support from APAAACi, WOW. At the time, Ruby Pawanka was the president of WOW. We had the support as well from the American Academy, American College, APAAACi, and SLY. So at the end of 2015, after thousands and thousands of emails and trying to discuss with the WHO, we have been then invited to Geneva in order to discuss the possibility of the inclusion of a chapter addressed to these our conditions. So in fact, this meeting was really productive, really positive, and in February 2015 we started the process of including each condition in the ICD11 platform. So as you may see in this next slide, we have been building this proposal, and now we have a section specific for allergic and hypersensitive conditions. It was a lot of work. You cannot imagine, because in this section we have more than 400 conditions, and for each line of this chapter we have to discuss with all the specialists, experts related to this condition. For example, for this, the anaphylaxis, for example, what we have been working a lot, we have to discuss with pediatricians, internal medicine, pneumologists, dermatologists, and so on. So it was a very huge work, and each line have been being requested by the WHO to be supported by evidence-based. It means publications and synonyms, and the content model was really complex. So it was a lot of work, but it was worth it, because now we have more visibility in this international platform. As you may see in the next slide, I brought an example from allergic rhinitis, for example. When we look for this condition, we can reach allergic rhinitis through the new chapter in which allergic conditions is now classified. That means the chapter 4. That is diseases of the immune system, and but through the diseases of the respiratory system as well. So, and under this allergic rhinitis, we have sub-conditions that give more detail for the disease. As you may see in this next slide, we can now provide much more detail for this, because there is a mechanism that's called post-coordination, in which we can combine the main term, for example, allergic rhinitis, and we can provide the severity, for example, or the etiology, because now we have allergens here in this chapter. That's the chapter 11, called external causes. As you may see in the next slide, we have been working a lot, not only to build up the new classification, but to prove the accuracy and the use of the new ICD11. This work has been done based on the data we selected in 2012, in which we analyzed more than 300 records of anaphylaxis deaths, and in fact we review all the data from the ICD11 perspective, and what we rated in this research was very high accuracy and very high sensitivity of ICD11 when we analyzed and applied this concept. As you may see, it was not, in fact, a matter of classification that was the problem. Next slide. It was as well a problem of coding the rules related to this misclassification. In fact, the WHO have never considered anaphylaxis nor the other allergic and hypersensitive conditions as underlying cause of death, because in fact they have been very badly classified. Now we have a section, and after that we propose a systematic review in order to prove the need of changes, and in which we publish this data and provide it to WHO. And the good news is that now we have changes in the ICD11 coding rules for mortality. So now we have not only anaphylaxis, but all allergic and hypersensitive conditions able to be underlying cause of death. Next. So, in fact, all these processes have been highlighted in this paper. If you wish, I will, in the last slide, leave my email address. All the papers are available. I can send you if you wish. So, but more than describing the changes of the history of mortality and morbidity statistics, we have as well, next, working in other classifications related to the WHO's, for example, the ICF, that's the functioning. We have been as well working in the ICPC, that's addressed to the primary care, and so on. And due to all these efforts, we have in 2018 been nominated here in the Montpellier Center as the collaborating center, but it's the only collaborating center that covers allergic conditions. What is really positive for us, although it's a lot of work, it's a lot of responsibility implied in this nomination, it provides us the possibility not only to increase the visibility of our conditions in the international classifications of the WHO, but as well we can improve the conditions in terms of public health. So in the ICD11 has been presented to the WHO and the World Health Assembly together with all the ministers of health of all countries in May 2019, and has been fully endorsed. So for now, we are working in the implementation process, and of course, the deadline established by the WHO is 2022. However, it depends on the health systems and the possibility of adapting the system to the new classification. So, in fact, with this, we have now all our conditions visible in from the international perspectives, and it provides us next. In other words, it provides us the possibility of increasing the awareness of terminology and definitions of allergic conditions. For example, we recently published this paper that's related to the global implementation of the ICD11, taking our conditions as example, because in fact, when we peer review terminology and definitions, we prove that it's worthy to have them as a tool worthwhile to in terms of epidemiology. So in this paper, we had the representation of 74 countries from all WHO regions, and the main conclusion was that we have a very good accuracy of all terms and definitions we proposed. And more than that, we do know that anaphylaxis is a key issue, but we do not have the key treatment for this condition. So why, as the only WHO collaborating center for allergies, I believe is our obligation as well, try to bring more actions related to our conditions. So why we have been trying to push this, for example, in this paper, in which we propose an action plan for the global availability of these devices based on 5 actions, and basically it's as well related to strengthening the awareness and prevent anaphylaxis. As well as prevent anaphylaxis, we have been working in different levels of prevention, and recently we propose this timeline in which we combine efforts not just for anaphylaxis in terms of morbidity and mortality, but actions related to all the health system. With this, I believe that we will reach a lot of benefits for our patients, not anaphylactic patients, but all allergic conditions related patients. So, in fact, we will have at the end the same aim of the WHO and of considering allergic and hypersensitive conditions as non-communicable diseases and having universal health coverage in order to provide quality health to everyone, everywhere. So I thank you very much for your attention, and I hope see you soon. Thank you very much.
First of all, I'd like to thank Professor Pascal de Molly and Professor Luciana Tanno, not only for the excellent talks that they delivered today, but for being the power, the force, and for all the hard work that they have put together over the years to actually change the scenario for allergy globally. This work of ICD11, allergy in ICD11, is a huge task and is actually a game changer. We believe that this has multiple impacts, not just now, but in the future. So we really thank you from the allergy community, starting from my presence as WOW president to now an APAAACi, and we really deeply thank you for all the efforts and wish you the best and assure you our full cooperation in all your efforts. Having said that, I'll start some questions. And my first question to Pascal is, Professor de Molly, is the importance of ICD is crucial for health coverage as well as for statistics of disease burden and mortality and morbidity, as you also highlighted. In order to include allergy in ICD11 and the public call that was made open when it actually happened, what was the actual initiation that you made, or what was the thought process behind your effort to try to work towards bringing allergy into this, the whole concept? Because the concept came from y'all. Y'all made the effort to try to. So how did you conceptualize it?
Well, thank you very much. First of all, Ruby, for the kind words and the support. I mean, it feels good to be part of a big community, and you've been so kind with us for that. And actually, doing so, you're being kind with the whole community. We are clinicians, and I think it all starts with our daily clinical work. And most of our hospitals nowadays have asked us not only to see the patients, of course, that are our task, but also to bill, sometimes on their behalf, the acts and the consultations that we are having. So in some countries, it's mandatory for a doctor to bill, otherwise is not going to be paid, and or the patient is not going to be reimbursed. So and I guess that is why the health ministers are so keen on the ICD, because they use it as a billing tool. Luciana and I, starting from this clinical fact that it's very hard to code allergic diseases, have actually taken the path of an academic tool, because we know so many fantastic publications that are actually digging disease from a huge database using the International Classification of Diseases. And because it's a classification that is worldwide utilized, it allows us to make comparisons between countries, which wouldn't be possible just because of language differences and differences in concepts. That asthma may not be asthma in Indonesia as it is in France or Japan, because we're using slightly different words. But with the coding tool, we can really use it as a research tool. And that was the main driving force.
Thank you very much. My second question to you is, if I remember right, we had a survey that was done, which you initiated, you and Luciana initiated, which was done by Yaki and Wow, where I remember working on it together with you all, looking at the different questions that you were going and to give a kind of a public survey. So how did this public survey help in developing this chapter for ICD11?
You remember very correctly, Ruby. Yes, it did start after the pioneer work of Luciana using the Brazilian death certificates. It really did work by the international survey. Why we did that? For two reasons, I would say. First, to warm up the community and make them sure that we, the leadership, if I may, are working with them and are going to help them in this issue. Actually, most of us have abandoned the issue of ICD. We all know that the ICD-10 and 9 in some countries, when we started, some countries were still using the ICD-9 because they knew that the ICD-10 was bad for allergic conditions. So they were using ICD-9 that is supposed to be slightly better for allergic conditions compared to 10. So the first reason was to warm them up. We are here, you elected us, but we're doing something for you guys. And the second one is actually to know what they were using because of the disparities. Some countries were using ICD-9, some the plain ICD-10, and some others were using national adaptations of ICD-10, like the US, like big countries like the US, Australia, Canada, and others. So we really wanted to have a picture of what our colleagues were using around the world.
Thank you very much. That clarifies very well. And in fact, I was going to ask that question about ICD-9, but you've covered it very nicely in your answer. So that's really good, because, US was far behind other countries in using ICD-9 when the rest of the world was using ICD-10. So you've clarified that. Now, my question is to Professor Tanno. So, Professor Tanno, can you explain how this is changing the specialty of allergy, both for the doctors, the clinicians, as well as the patients? How is this going to change?
Well, we have many aspects in this question, Ruby. Thank you very much for this. And thank you very much as well for your support. It's a great pleasure to have this webinar and have been working together with you. So in fact, from the clinical perspective, we have two things that can be go directly to the clinical practice. First is the reason why I started this research. When I started this research, it was in fact based on the reality from Brazil, in where we do not have auto-injectable adrenaline for our anaphylactic patients. So my aim in this the first research was try to bring some data, mortality data, to trigger some discussion with the Minister of Health to have some changes in this big picture. So. But now, at that time, we had the issue of classification, and we started other process. I hope with all this move and all this work we have been doing with the visibility of our conditions in the ICD11, that we will be able to try to solve some issues that we had before. For example, the absence of these treatments that are essential medical devices for our patients, for example. This is the first one. The second is from the practical perspective in terms of billing, for example. We usually have coded our patients as allergy unspecified, because we didn't have more details, and even for receiving patients from other specialists or colleagues for evaluation, they address us with this code that's allergy unspecified. But now, as far as we have more details, we may be able to have specific data and have a better tool for billing as well. So I believe it will be positive at the end.
Yes, I mean, I fully agree with this, because especially for health insurances, you know, in some countries like India, for example, asthma is not covered by health insurance. I mean, we don't have a national health insurance in India, but unlike Japan. But even the private companies, they don't cover asthma, saying it's a pre-existing condition. So I think something like this, when ICD11 actually gets implemented in 2022, that this would be a game changer in helping patients with asthma get coverage for their treatment. My next question to you, Professor Tanno, is that do you conceptualize that this change in, or having allergy now in ICD11, of course, it gives importance to the field of allergy itself as part of NCDs, because otherwise previously nobody considered allergy is part of NCDs. They talk about everything else but leave out allergy. So, you know, this gives a big push to it. But do you think this also would help the industry as they develop new treatments like biologics, that this kind of a coding what is your view on it?
Yes, we will in fact have a clear view of the market, because all the medications and new medications are now coded, because they are aligned to an online platform, and it's updated frequently, so we will not have issues in this way. And I will link this question together your comment before. For example, for biologicals, in some countries, we do not have them covered by the public insurance. And in some countries, such as in France, for example, the allergists do not have the right to prescribe them, even the anti-IgE, what is a shaming. But it will change in the next few years. And the idea is, as far as we have the proof of the need of these medications, we will have argumentations to have this this covered by the health insurance, the health insurance in terms of public health and so on. So I believe it will trigger a lot of work as well. As far as we have more visibility of the conditions, we will have as well more investments on this this field.
Thank you. My next question is, like, you are aware, and I think you covered that also in your talk, that there are many countries that do not have EpiPen or adrenaline auto-injector, which is actually, for me, when Margaret Chan was DG, I said that EpiPen should be like an AED. You should have it as a set, because it's really a life-saving device and you need to have it. How they keep it, or how they because it's not like a device, you need to, it has expiry dates and things. So I mean, that kind of monitoring or control can be done in a different way, but almost every restaurant, almost every mall, every airline should have EpiPen. You know, it should be an essential drug, and this was something I tried to push for a lot during my time and during when she was the DG. But what I'm trying to ask you is that many countries still don't have EpiPen or adrenaline auto-injector, and many countries are not even aware of anaphylaxis, the condition of anaphylaxis. Like if you ask some places, they don't understand. They will just say some you know, like cardiac arrest, or you know, something like that, and as a cause of death, they would never use the terminology anaphylaxis. So I believe that this would probably help in changing that whole concept. And what do you think? You think this will also help in getting adrenaline auto-injector as an essential drug or mode of treatment, or an emergency kit like an AED?
Yes,
do you
definitely, Ruby, is one of our tasks as a collaborating center covering allergic diseases as well, is trying to bring this issue and try to reach the solution for this, because of course we have a lot of interest and political issues related to this distribution, but I don't think our patients deserve this. We should try to bring this up, and meanwhile we are working in this initiative as well. We have been working together with the WHO in terms of the awareness, so education, training tools. So I believe it will be very, very helpful for allergy to have this more visible. And of course, the support and alignment together with all allergic international societies is mandatory, because we have to work together in terms of awareness and visibility.
Absolutely. I couldn't agree more with you. And I think from our side, we will do our very best to get this also into languages that are people, you know, because, you know, like asthma is not called asthma in like, as you mentioned, in some countries, different terminologies are used, different, some people use sinusitis for rhinitis, things like that. So I think getting this also into different languages, trying to kind of promote this at various levels globally across the world, I think this is a key thing. And I think your center, the WHO center in Montpellier, I think really congratulations for that too. So I think that would be a key center to help you know, be the leader of that, and to work with all us international societies to make this actually practical and implemented in real life. So I'd like to end my questions by congratulating you again, and welcoming you again to work closely with us. And we are very, very happy, very proud of you.